everyone, and thank you for joining our workshop today, which is titled How California's Algorithmic Vaccine Distribution Affected Racial Justice and Health. My name is Jennifer Jones, and I will be moderating this very timely and critical conversation today. Before I jump into an overview of today's workshop, I'll just share a little bit more about myself and give my co-panelists an opportunity to introduce themselves. I use she, her pronouns, and I currently work as a staff attorney with the Technology and Civil Liberties Project at the ACLU of Northern California, which is based in San Francisco. And our project is primarily focused on fighting for justice in the digital age. We work to ensure that technology serves the people instead of the interests of the powerful and the privileged by uncovering and challenging government surveillance practices, and by defending and strengthening the right to privacy and promoting corporate accountability for protecting people's privacy rights. As you can imagine, the events of the past year have really brought into sharp focus the increasing role that technology plays in all of our lives, and the role that it plays in how government entities address the many challenges that we are confronted with in this very critical moment. So with that, I will let my colleague Jacob Snow briefly introduce himself.
Hi, everyone, and thanks a lot, Jen. Appreciate it. It's a pleasure to be here, and it's a pleasure to be appearing virtually at this Upswell conference. My name is Jake Snow. I use he, him pronouns. I am a senior staff attorney in the Technology and Civil Liberties program with Jennifer at the ACLU of Northern California. In that work, I work on consumer privacy, government surveillance, free speech online, and algorithmic fairness as well. Looking forward to this. Then I'll pass it to Crystal.
Hi, everyone. My name is Crystal Grant. I'm a technology fellow with the nationwide ACLU here in New York. And I work at the Speech Privacy Technology Project, mostly around issues in algorithmic fairness and bias, as well as genomic surveillance and privacy, since my background is in genetics. And yeah, I'm really excited to get this talk started today. I'll pass it back to Jen.
All right, thank you, Crystal. So for just a quick overview of what we'll be discussing today, we'll start by hearing from Jake about the ACLU of Northern California's research around an algorithm that California has been using to promote equity in COVID-19 vaccine distribution, and what that research tells us about the use of technology in addressing health equity issues. After that, we'll hear from Crystal, who is going to provide us with some historical context around race and medicine, and the ways in which that history drives health and clinical care today, including what we're seeing is the increasing use of algorithms to make public health and medical decisions. And then we'll wrap up with a brief discussion of how these technologies being used to make these critical decisions around public health can be regulated at the state and federal level. Hopefully at the end, we will have some time for Q&A. So if any questions do come up during the presentation, please do feel free to put them in the chat. So before we jump into Jake's research, I'll just sort of lay the foundation for the last year and a half, where we've been witnessing a lot of technologies being relied upon to address and navigate the COVID-19 pandemic and the very sort of overwhelming impact that it has had on really every aspect of our lives. In some ways, I think this has proven helpful and beneficial to a lot of people. I think one salient example of something positive is how telecommuting has sort of improved accessibility for people with disabilities, and technology has certainly enabled that. In other ways, however, technology intended to address the many issues that have arisen under the pandemic have sort of proven to be questionable, if not actively harmful. And one trend that we've been seeing a lot in California and nationwide is this increasing use of surveillance systems by public school districts to monitor all student activity while they're using their computers or social media. And this surveillance is really invasive. It includes, scanning students' emails, chat messages, other documents like class assignments and personal files. And these systems are searching for keywords that could indicate self-harm, violence, or sexual behavior. And purportedly, these systems are intended to keep students safe. What we're actually seeing, however, is that students find algorithms like these to be quite scary a very egregious invasion of privacy that really works to increase the chances that kids will be punished or come into contact with law enforcement or the family regulation system and other systems that we know are very harmful, particularly for students of color and LGBTQ children. So while I think we would all agree that keeping students safe is an important goal, this sort of over-reliance on tech to get us there can really fall short or even prove to be counterproductive and show us how these systems are often inequitable and ineffective, despite having very noble policy goals. So that's one example that has come up in my work. I know that the ACLU of Northern California's research around the vaccine equity algorithm presents another really interesting example of the limitations of tech in addressing health equity issues, particularly the racial disparities that we've seen with how COVID has disproportionately impacted people of color. So now I'm going to turn it over to Jake, who is going to provide an overview of that great research and also tell us what it means for advocacy in this space. So Jake, I will pass the mic to you.
Thanks a lot. Really appreciate it. And I'll start by talking about the genesis of the research that we did at ACLU NorCal relating to vaccine equity, and then talk about the results and some of the implications of it. I think there should be a link to the blog post that we did in the chat on the Hulu platform. So hopefully folks can see that. There is a interactive map on that in that blog post, and so I'll show some of those maps and show the results. No need to look at it, but if you want to look at it while I'm talking, that might be interesting as well. So to give some context here, let's go to the next slide. I served on the Community Vaccine Advisory Committee for, let's see, so I just see a blank slide. Oh yeah, there we go, great. For the Community Vaccine Advisory Committee for the California Department of Public Health. And that committee was a convening of a group of community and equity groups to advise the Department of Public Health on distribution of the vaccine, and in particular distribution of the vaccine in a context where vaccine doses were scarce. Late last year, in December 2020 and early this year, doses were just starting to be available, and there was a lot of discussion, a lot of important discussion about who should be given those doses as they start to trickle into states around the country. And this committee was helping to advise the Department of Public Health on that question. And in our view, at the ACLU, it's vital that when scarce resources are distributed by the government, that equity informs those distribution and policy decisions. Specifically with respect to the pandemic, we know that the pandemic has devastated Black, Latinx, and other communities of color at disproportionate rates. And so the distribution of vaccines, when those vaccine doses are scarce, as they were earlier this year, really needs to take those realities into account. And so, asking questions about exactly how that distribution will work and how the algorithm will work is important, because it's life or death decisions that were being made by the government, but it also has implications far beyond that vaccine distribution. When the state uses some kind of algorithm to make life or death decisions, whether it's in the criminal legal system or for public health, or in the family regulation context, as Jennifer was describing, it's important to think about the obligations of government to inform people of the inner workings of those algorithms, because it's not entirely people making those decisions. It's an algorithm. And so what are the responsibilities of government to inform the public of how those systems work? So let's get into some of the details of this system and what we did in terms of the research. How did the state plan to distribute vaccine supply across the state? Maybe you go to the next slide. So you decided to use something called the Healthy Places Index. The Healthy Places Index assigns a score to each place around the country, around the state. And that score is based on a number of factors. It includes access to health insurance, it includes income, average income in the place, health outcomes there, environmental factors as well. And so across California, some places are healthy, and that's primarily going to be wealthy areas of the state. A lot of disproportionately white areas of the state where that health and that wealth is concentrated. And then some places are not healthy, and that's going to be less wealthy areas and disproportionately in California communities of color. So this slide shows the California Department of Public Health's plan for distributing vaccines. Now, what this shows is that 80% of the vaccines would go to the 4 what they call quartiles of the state under this thing called the Healthy Places Index. So that just means that 80% of the vaccines get distributed equally across the area of the state, and then 20%, that's the sort of like darker blue portion on the right of this slide, is saved for the lowest, kind of least healthy quartiles in the state. And so just sort of like in basic terms, that just means that 20% of the vaccines are going to the least healthy areas. And that's part of California's focus on equity here. And fundamentally, I think that's a worthwhile goal and important and praiseworthy policy goal that the California Department of Public Health was using. Can you go to the next slide, please? So now we have to talk about census tracts and zip codes. Census tracts are very small areas of land. This is Los Angeles, like the Los Angeles coastline. You can see that those red boundaries, which describe census tracts, are fairly small, a few blocks in each of those census tracts. Census tracts are areas of land that are used by the census to track populations and to track the metrics across populations, so income, demographic information, and other things. Let's go to the next slide, if I could. This is approximately the same area, but it's zip codes, and you can see that these zip codes are much larger, and there's many more people in them. And so the state decided to use zip codes when they were distributing this additional vaccine supply to communities around the state. And zip codes are much larger than census tracts. And so we wanted to ask the question, what would it mean when you take the health metric of the Healthy Places Index, which uses census tracts, these small, very granular, very specific, really neighborhood-focused areas of the state, and then you expand them, you aggregate them into zip codes, and then just give vaccine supply based on zip code. Well, the implications of that, I think, are, and this is sort of what our research was asking, was would there be places that when you have small areas of the state are disproportionately unhealthy and vulnerable, and they need a lot of public assistance, but who share a zip code with healthier, wealthier areas? Are there places that have both? And would the use of zip codes actually mean that some places that are not healthy would be deprived of additional vaccine supply because they're being grouped in with healthier, wealthier areas of the state because zip codes are the boundary that's being used? So that was our goal, to understand in concrete terms exactly how the additional vaccine supply would be distributed. So let's go to the next slide. So let's go to the next slide as well, and that'll show the map of California with the sort of very high level results here. So this is all of California. And what these maps show is the blue areas are the areas of the state in California, which are the zip codes that are getting additional vaccine supply. And then the red areas are the portions of the state which, despite being having poor health outcomes, have lower income, having lower access to health insurance, access to clean water. There's environmental effects as well that are taken into account. Despite those problems and that lack of access, these red areas are not getting additional vaccine supply under California's algorithm. So this is a very high level, sort of 30,000 foot, almost literally, view of the state. But let's zoom into a particular neighborhood and look at Los Angeles. Let's go to the next slide. Especially downtown, is of unhealthy outcomes there. There's a lot of poverty, and income access to healthcare is disproportionately low. You see in the center of this image, the blue areas that are getting additional vaccine supply. But as you get into the outer part of the downtown area, and you can see that there are pockets of red. And those pockets of red are areas of the state which are disproportionately unhealthy, not getting additional vaccine from the state because of the decision to use zip codes. So then that's what we see in this analysis. We see that there are hundreds of red areas of the state on these maps where people who need the additional healthcare live. These are disproportionately disadvantaged areas of the state. They've been deprived of wealth, deprived of access to healthcare, and yet, even though the state has a stated goal of seeking to enhance and consider equity in distributing additional vaccine supply, these areas are being left out and they're not getting additional supply. They are in effect being treated as if they are healthy and wealthy, like their neighbors. As I said, this is true across the state. We go to the next slide and take a look at downtown San Jose, where here there are no, in this map, there are no areas that are getting additional vaccine supply because all of the areas that are red here were close potentially to like a luxury apartment building in downtown San Jose. I actually used to live near here in San Jose, and there were a whole bunch of luxury apartment buildings built there. And so it's possible that a lot of the people who live in these red areas would be deprived of additional vaccine supply because there were recently wealthy and disproportionately healthier people who moved into those places. True also of other places in Southern California. Go to the next slide, which shows another more specific neighborhood in Corona in Southern California. So those are the maps, and again, an interactive map showing all of this is on the blog post that hopefully y'all have a link to, and happy to discuss other areas as well. So let's go to the next slide and talk about some of the sort of statewide findings here. Next slide. So as I said, the state has a goal here of promoting equity in vaccine distribution. The concept of delivering additional vaccines to struggling Californians, I think, is a worthwhile one. But unfortunately, because of the decision to use these larger area zip codes, 2 million struggling Californians in total in these 470 approximately areas of the state might have been left without additional vaccine supply. They might have been treated as if they are healthy and wealthier. Next slide, please. And in the Bay Area, where our office is located, there were 200,000 people who may not have received additional supply from the state of California. And those 200,000 people may have left without additional supply because a building was built down the street from them, something that doesn't help them, but which in this, because of the details of this analysis and the decision to use zip codes, would deprive them of additional help from the state. Next slide. We're also seeing the racial disparities show up. If you look at those red areas of the state, 53% of those are Latinx people, but statewide, they're only 38% of the population. So Latinx people are disproportionately represented in those red areas. Please. And the same is true of Black people in California. Statewide, but they are 8% of those red areas that are not getting additional supply. Next slide, please. Just one sec. Okay, so in this work, I just want to acknowledge the technical assistance of both Max General and University of California, from the University of San Francisco, not University of California, just USF, Center for Applied Data Ethics. You can look them up on Twitter here. They provided really instrumental and helpful technical assistance. We would not have been able to do the analysis or build the maps that we did without their support. And kind of fundamentally, I think the takeaway here should be that when algorithmic systems are used to distribute scarce resources, we have to be brutally honest about the consequences of using those algorithms on people's lives. Technology really can alleviate harm, but it can also exacerbate existing inequality or leave that inequality in place. And the results of our research, we hope, will advance California towards both transparency in algorithmic systems and equity, and ensure that technology is powering social justice rather than undermining it. And I'll stop there. Thanks a lot.
Wonderful. Thank you so much, Jake. That was very illuminating. And I know we all really appreciate the work that you're doing in this area. I know that this issue of grappling with how to address racial health disparities has a really long history. And I think Jake's work for me brings up some questions about that history and sort of broader problems with race-based medicine. So Crystal, it would be great if you could touch on some of this history and describe how it has sort of shaped technologies that are being used in healthcare today.
Okay, so yeah, thank you so much, Jake, for that presentation, especially like ending on the note of how important it is that we consider the effects of these algorithmic decision-making tools. I'm going to be talking a little bit more about the use of race in healthcare and medicine, and the times that it makes sense to factor this in, kind of like what Jake was just talking about in the public health sense, and other times where it maybe doesn't quite make as much sense. Can we go to the next slide? So the COVID-19 pandemic has brought national attention to racial disparities in medicine. We can see just how stark the differences in how this virus has affected different racial and ethnic groups in this graph here from the CDC, where along the x-axis is different racial and ethnic groups, and along the y-axis is the percent of COVID deaths relative to their age-adjusted population distribution. We see that for for different people of color, that this is a really high percentage relative to their effect of COVID-19 is really high relative to their actual population distribution, as we know that this virus has disproportionately affected people of color. And we learned this really early on. I think it was like April 2020 that studies came out that started to suggest these really dramatic racial differences in COVID. And this was actually something that made it to, that gained congressional attention. So if we go to the next slide, there was a, so I think this was June 2020. There was actually a subcommittee hearing on COVID, specifically about the disparities by racial and ethnic group. And I think there was this really, if you blinked, you would have missed it, but this moment that really kind of illustrated what often happens in health and in medicine when people observe that there are racial and ethnic disparities, where Congressman Foster brought up the question of whether racial disparities in COVID are due to a genetic component, citing a study that found that this protein that interacts with the spike protein in COVID appears to maybe have racial differences, although the study itself was pretty inconclusive. But still there were kind of whispers of, well, we're seeing racial differences, it must be genetic. And then in the next slide, like immediately after the congressman saying this, Dr. Uche Blackstock, the founder and CEO of this really great organization, Advancing Health Equity, kind of tried to set the record straight, making it clear that it is not race, but geographical ancestry, which is very different from race, which is a social construct that seems to be what is driving these differences in the effects of COVID-19. And as I mentioned, it was like a blink if you missed it moment. It was very quick, but I kind of want to talk a little bit about this distinction here and why people often make this mistake when they do see racial disparities of assuming it's genetic when it is not. So if we go to the next slide, we can see that racialized medicine has its roots in eugenics, where it was often used to justify white supremacy and enslavement. So the field of eugenics used incredibly unscientific methods to perpetuate myths that non-white people were innately inferior. These were methods like trying to measure differences in skull volume as proof of cognitive differences, or just other very unscientific methods claiming that they were science. And they all kind of had the same finding that the non-white subjects were of overall weaker health physically, or overall like lower cognition, kind of you name it, or that they felt less pain. And unfortunately, a lot of these beliefs are echoed in medicine today and are now being built into medical like AI and algorithmic tools. Some examples which I'll get into are the differences in cognition, which we see in algorithms today used to calculate cognitive decline. There was recently one in the news in that the NFL used this algorithm to incorrectly claim that Black players already had a lower cognitive ability before being in the NFL, which obviously is incorrect. And it kind of abounds across different parts of medicine and health. So overall, it's really scary to see how these studies that were clearly rooted in eugenics are being repeated and in some ways automated today in our medical technology. So if we go to the next slide, we'll talk a little about the idea of a biological basis of race, where in short, there is not one. Race is a social construct without a biological basis, yet is still informed. It's still used to inform our health and clinical care. And the reason that it is that is that it's often used as essentially like a shorthand for genetic information about an individual, although this isn't necessarily useful at the genetic level, where instead what would be useful is information about ancestry and ethnicity, as these actually can be linked to the genetic base and biological basis of disease, rather than kind of flattening groups into like overall continents. This is especially vital to keep in mind because a lasting effect of eugenics has been this incorrect belief that most humans, if you break them down into racial categories, show these huge like genetic differences between them, when what is important to remember is that all humans are, I think it's like 99.9% identical in their genetic makeup. And another reason that in health and medicine, it's especially problematic to try to use race as a proxy for biology is that, race is not really standardized across different like countries. And also when we look at the level of like our genetics, it's actually kind of meaningless. So on the next slide, you can kind of see where I mean, where so this is taken from the paper kind of in the lower right-hand corner about different groups. And an example often used in medicine asks kind of whether a patient is Black or not, which especially doesn't work because there's a huge diversity in what it means to be Black. And you can kind of see in this graph here, which looks at the entire like genome of several different groups, where the red represents European ancestry, the Y represents your best sample is meant to represent African ancestry, and green is Native American. And we can see there's a block that says African American, that it can be up to 60% of African Americans actually have for some African Americans, up to 60% of their DNA is European, which is why it especially makes very little sense for some medical algorithms that look at someone, attempt to assume their race, and then from that infer their biology. When for some African Americans, there's no way to know in their at the genetic level whether they are expressing more African or more European genes. So I think this is just a really interesting visualization, and it is people who identify as Black, whether they're African American, Brazilian, Jamaican, and we can see that there is a ton of mixture. So it's really unclear at the level of genetics kind of what is being represented. So on the next slide is kind of what I was alluding to earlier about how this little short background primer of race in medicine and why it doesn't work, why it is especially troubling when these broad categories are placed into algorithms that kind of flatten and treat everyone as though they're the same, where algorithms are increasingly used to make public health and medical decisions, and it can decide anything from what Jake was mentioning about who to where vaccines should be distributed, all the way down to specific things about which patient should receive care and what that care should look like. Yet we know that these algorithms can reflect biases and beliefs of the people who design them, which I'll get into kind of specifics on the next slide. So we can think of there as being kind of two different algorithms, and one in this case is trying to model biological differences. So in this case, they might look at the scientific literature, which, keep in mind, for a lot of these has their basis in eugenic findings from last century. Will compute data of people from different groups, and then will like on the outset, so as we kind of move from left to right, and then we'll recommend possibly different treatments for people of different races based on perceived differences in the literature. But in the next slide, I'll mention a specific algorithm where this doesn't work, and was actually, this practice has been changed of offering different treatments to people based on their race. So this paper that was published, I believe, this year, looked, essentially there is an algorithm where they used the scientific literature from the 1990s. There was a very small study that purported to find differences between Black and white patients, like really extreme differences, and then suggested essentially different treatment for them, although more recently, there's been pressure on the use of this algorithm because it's believed the differences that were found are actually not quite as existent or as stark as was thought. And they found that by essentially recalculating and not using this race correction in this algorithm, that a lot of Black patients would have seen their treatment really dramatically change. And would have been classified as being more sick to reflect how they actually were. So this is a case of using a medical algorithm to model biological differences between groups, and it not really being true, and finding later that it's actually causing a lot of harm. In the next slide, I'll talk about how these tools can instead model sociological differences, which makes a little bit more sense, but can still be prone to error. So I'm kind of moving from left to right. These models are trained on electronic health records. Algorithms are developed and then can suggest different treatments for different groups. Or sorry, not different treatments, can suggest, based on health records, who is more likely to be more sick versus who is more likely to be healthy. And for example, so it would maybe help with a very scarce resource of medicine to decide to whom to direct more care. But in the next slide, we see, again, there's a publication with algorithms with this approach, also finding that they can reflect racial bias, where this paper from 2019 found that an algorithm used on hundreds of thousands of patients across different hospitals, because they were trained on electronic health records that themselves encode historical biases, that algorithm was then also showing bias. In this case, it was through sociological differences, where because they found that people of color tended to pay less into the medical system for lots of different like sociological reasons of maybe not being able to afford it, that they also, and because the algorithm was using essentially payment amounts to predict how sick someone was, because these people could afford to pay less, they were actually suggested to get less care, which is kind of a clear case of a model of sociological differences also reflecting bias. So in the next slide, there's a third essentially kind of branch of medical algorithms that is especially frightening, in that they are able to discriminate on race even when it's unintentional. So in the last two algorithms, one explicitly was trained to take race into account, even though this wasn't really meaningful and shouldn't have been included. And another algorithm actually was purposely race blind, but still was found to show racial discrimination because it was using this data that showed historical biases. This new publication from earlier this year, or pre-publication, found that an algorithm that was trained on chest x-rays has for some reason learned to tell the different races of the person being x-rayed. So this is especially frightening because it's an example of an algorithm in health and medicine that may be able to discriminate even when a human would not be able to, and that a trained like radiologist cannot look at these images and be able to tell the race of their patient, but this algorithm for some reason has learned to. And so this is essentially a good motivating factor of why there needs to be a better understanding of algorithmic bias in health and medicine, as we're starting to move towards tools that are able to essentially discriminate even when people cannot. And so yeah, that was meant to be a primer of the use of race in medicine, how it can sometimes be useful in the sociological context to detect historical like differences in treatment or the effects of racism in health, and in other contexts in which it's maybe not appropriate, where it assumes that there exist biological differences where there are none. And ending here with the invention of these new tools that seem to be able to discriminate even in the absence of human programming or even human desire to have them discriminate, as the developers of the algorithm definitely did not want them to learn patient races based on images. And so in the next part of the talk, I can just talk briefly on the next slide. I can just talk a little bit about the regulation of these medical algorithms and technology, and essentially who is responsible for ensuring that that these tools are free of bias. And so if you go to the next slide. And Jake, feel free to talk about CPPA. So essentially, the regulatory agencies that can address bias in health and medical algorithms and technology are like three that are especially relevant are the Food and Drug Administration, the Federal Trade Commission, and the California Privacy Protection Agency, where all three essentially have different levers to ensure that software developers or manufacturers of these tools are ensuring that they are functioning correctly and are not reflecting racial bias. And so for tools directly used in medicine, that's kind of where the FDA would come in, where they can essentially require that these tools be evaluated for biases or inflated error rates between different racial and ethnic groups. Additionally, they can require that it be made public the demographic information of the tools on which of the data on which these tools were developed and tested, which could be an important step towards transparency. And then the FTC would be more towards tools that are not used directly in the medical setting, where they also are able to ensure that regulators are not perpetuating biases. And I believe that CPP has sort of similar tools. I don't know if Jake wants to talk about that.
Sure. Yeah. Thanks. To add one point about the FTC, where incidentally I used to work, they have authority to regulate unfair, deceptive business practices, and so we've seen some cases coming out of the FTC. The one that I think is sort of worth looking at if you're interested is called Everalbum. And what happened there is a company took photos from a consumer photo app and then used it to build essentially military surveillance technology, a facial recognition tool that it sold to the military and to the police. It did that without really telling people that it was taking people's family photos, photos of their children, photos of their friends, and building the facial recognition using those photos and then selling it to law enforcement and to the military. And so that inadequate disclosure, according to the FTC, was deceptive, and so that's the basis for the FTC settlement in that case. One thing that was kind of interesting about that is that they actually required the company to delete the algorithm that was built using these people's photos who weren't adequately informed about it. And I think that's a powerful remedy when companies are facing down the possibility of the algorithm actually having to be deleted, or the model having to be deleted. To touch quickly on the California Privacy Protection Agency, for folks outside of California and potentially for folks inside of California, you may not be aware that there is a new privacy protection agency that was created in accordance with a ballot measure that passed last November. And part of that agency's authority is to promulgate regulations on the use of automated decision-making technology and consumers' rights to opt out of that automated decision-making technology. The agency is just getting off the ground. There's like a single-digit number of people who work there now, but they have asked for public comment on how they should exercise their regulatory authority over automated decision-making systems. And so that's an area where I think it's worth watching as well for the beginnings of what a regulatory framework will look like in the algorithmic space. So that's a place to look. And of course, if folks are interested in submitting comments, check out the agency's website and you can submit comments there. I think they're due in the beginning of November.
Wonderful. Crystal and Jake.
Oh, I've got one more slide.
Sorry.
Sorry. Yeah, so thank you so much for that addition, Jake. And so on my last slide, I talk about other stakeholders who can contribute towards debiasing efforts. In addition to what we just mentioned in the previous slide, where this can be those working directly at hospitals and other medical systems can kind of do their due diligence and not using AI or ML tools that have not been cleared by the FDA or been published in a peer-reviewed study where especially with COVID-19, there have been a lot of like AI tools to try to predict who is at higher risks, and it's been found that a lot of them are not functional and haven't even been evaluated for bias. This is just something that people working directly in medical systems can do, as well as continuing to push for evidence-based algorithmic decision-making tools, where I mentioned the tool that purported to observe racial differences in like kidney function between Black and white patients was actually recently suggested that they kind of remove that racial distinction for patients and use other more informative ways to decide patient risks. And this was due to medical student and staff, essentially like activists, continually bringing up that this is really not a good practice to use race as a proxy for biology. Similarly, medical educators can ensure to try to push for minimum standards of education in algorithmic decision making among those in medicine, so they essentially are more comfortable interacting with these tools. Those developing these AI and ML tools can ensure that they are performing impact assessments for disparate impact by different groups. And manufacturers can also work with researchers to try to find best practices in detecting algorithmic discrimination, or even just making their data available so that researchers can check and ensure that they're not finding biases. It was kind of like what Jake was able to do that you talked about a little bit earlier. And yeah, so that's it for my talk. Thanks so much.
All right, great. Thank you, Crystal. Thank you, Jake, so much. We do have a little bit of time to take some questions from the audience. So if you haven't already, please do drop your questions into the chat. To lead us off, I do know that we have a question from an audience member, Hannah, who wants to know how the state of California responded to the ACLU's research around the COVID-19 algorithm. Jake, do you have an update there?
Yeah, so the state responded by saying that sort of, first of all, they didn't dispute the sort of conclusions of our research. So, you know, the fact that 2 million people lived in these areas that would be deprived of additional vaccine supply, 469 different places across the state, would be deprived of this additional vaccine supply, despite the fact that they were unhealthy, according to the Healthy Places Index. So the sort of results they didn't dispute, and I think that's important to highlight. They did say that the reason why that they decided to use zip codes rather than census tracts was because people know their zip code, but they don't necessarily know their census tract. So a census tract is something that's harder to identify and associate with a person. And so they wanted to use zip codes because they could ask someone what zip code they live in, and then they would be able to determine where the vaccine supply, the vaccine dose that that person was given, or that person was sort of signing up to receive, would go. And so for tracking purposes, it was important to them to use zip codes because people know it rather than census tracts. I will say that in the sort of surrounding discussion, there was a lot of public health experts who said that there are ways to get people's census tracts by asking them to point to where they live on a map, or to share their location that can be used for just that purpose, or to ask them the intersection that they live at. And so those sorts of things would allow census tracts to be used to distribute the vaccine supply. And so the state gave practical reasons that people know their zip code. And then also that was responded to by public health experts who said that you actually could do it even using census tracts. The other thing that I'll highlight is that this discussion, I think, needs to happen in public. And if the state says, like, there are practical reasons why we have to deprive 2 million unhealthy people of access to vaccines, they might be right about that. But the cost of it is, in fact, that 2 million people in hundreds of neighborhoods around the state are deprived of access to healthcare that they need. And so from my perspective, thinking about using an algorithm for this purpose, that fact of the trade-off, and in all honesty, it's a difficult trade-off, and one that I'm skeptical of, is the one that the state is making. And so that's, I think, the sort of core lesson here, is that transparency should have been baked in from the outset. And I think also that it would have been practical to use census tracts, but that's sort of unknown fundamentally.
Great. And Jake, I know that your research focused solely on California and their use of the algorithm. Do you know if other states are using a similar tool, or if there are other folks that are looking into this trend sort of happening in other states across the nation?
Yeah, so there's a variety of approaches that were used across the different states. I think Massachusetts adopted something somewhat similar to the approach where they tried to identify areas in the state that were especially in need of vaccine supply, additional vaccine supply, and then would direct the limited supply they had to those places. But fundamentally, a lot of states, I think, just decided to set up mass vaccination centers wherever they could do so, and basically make vaccines available to people who could get to one of those mass vaccination centers or could get a vaccine dose from their healthcare provider. The problems with that, of course, are that people who don't have the transportation available to them, they don't have the time away from work or other things, are disproportionately unable to get to a place to get a vaccine dose. And so the making sure that vaccines meet people where they live, they meet people where they live kind of geographically, but also culturally, is really important. And so California took some steps in that direction, but maybe not as many as they should have.
All right, wonderful. So it doesn't look like we have any additional questions from the audience at this time. So Crystal, Jake, I just wanted to invite you both to share any final thoughts before we wrap up today. Anything that the audience should walk away from this workshop with.
I guess I'd say it's so vital to ensure that this technology is not reflecting biases, and that there are a lot of suggestions about kind of how to address that problem, including like increased transparency and explainability. But I think the very first step is to even get the people who are designing these algorithms to ask that question before essentially like releasing it to be used out in the world. So yeah, I think that in things like public health and medicine, it can really be life or death if we're not certain that these tools aren't reflecting biases and automating them. So I think that is absolutely vital that we're asking these questions and essentially pushing our regulators to do the same.
Yeah, totally agree with that. And I would add that that I think it's the other policy question that really needs to be top of mind for all of us as people and participants in democracy, but also for policymakers and regulators, is what are the uses of algorithms that should be prohibited. At ACLU NorCal, and Jennifer's done a ton of this amazing work. We've called for a moratorium on facial recognition technology, and we've also worked to pass bans in San Francisco on facial recognition technology. I think that's an area where the risks, both because of surveillance and also because of furthering bias from the past, the risks of technology are so great that the technology should not be used at all. And so as we think about applications of technology, one of the answers is that we should say no to that technology. So in the case that I talked about today, where an algorithm being used to distribute a scarce supply of a valuable resource, I don't think the answer is always no. But when it comes to facial recognition, given the factor that supercharges surveillance and has these bias problems, I think no. And so it's always worth, I think, thinking about when the answer is no and when the answer is maybe, and when the answer is yes, given certain limitations. So, but thanks a lot. Great discussion with Crystal and Jen, and appreciate everyone for joining.
Yeah, of course. Thank you so much. And I'd like to thank everyone who was able to join us today. We definitely hope that you're walking away with a better understanding of these health, race, and tech intersections that we discussed, and ideas for how to advocate to ensure that any tools that are used to address such an important issue are in fact working to remedy inequities. If you'd like to learn more about the ACLU's COVID vaccine equity work, I encourage you to read Jake's blog, which we have dropped in the chat. And feel free to reach out to any of the panelists, including myself, with any questions that you may have. I know that we had our email contact on the initial slide. But yes, thank you again, and I hope that everyone enjoys the rest of the summit.